Welcome to the Deep Dive. If you follow the news about U.S. healthcare, you've probably heard the term labor shortage just constantly.
Ad nauseum.
Right. And the typical narrative, it always focuses on post-pandemic burnout, stress, long hours, especially for nurses and doctors. And I mean, those factors are massive.
Oh, they are. They're huge.
Yeah.
But, relying only on that burnout narrative, it really misses the economic bedrock of the crisis.
The economic bedrock.
Yeah. If we really dig into the foundational data, and that's what we're doing today, we find that for a massive portion of this essential workforce, the problem isn't just about emotional exhaustion. It's about financial survival.
And that shift in perspective, that is the entire mission of this deep dive. We're taking a hard look at data from the U.S. Census Bureau's survey of income and program participation.
The SIP.
The SIPP,
Yeah.
right. Spanning 2020 through 2023. And our goal is to go beyond the headlines and uncover this hidden and frankly shocking instability among the very people who provide constant essential care.
What the SIPP data immediately throws into relief is that financial hardship is not. It's not a uniform problem in healthcare. It's profoundly unequal.
Unequal in what way?
Well, you have professionals earning high six figures working right alongside a massive essential support workforce that's struggling with basic needs, like food and shelter. The system is structurally bifurcated.
So we need to understand exactly why these essential workers are facing such fundamental economic struggles.
Exactly.
Okay, let's dive right into the core of the data then. Let's identify the population that is bearing the heaviest financial burden. The study points directly to one group above all others. Who are they?
So we're talking about the direct care and healthcare support workers.
Okay, and who does that include?
These are your certified nursing assistants, personal care aides, home health aides, housekeeping, kitchen staff, the people on the absolute front line.
The ones providing that consistent, physical, and highly personal support every single day.
That's them.
So what does the quantitative evidence actually look like for this group? How do their incomes compare to, say, a registered nurse or a physician?
The contrast is, it's stark. This group consistently reports the lowest personal and family incomes across the entire healthcare spectrum.
The lowest.
The lowest. The data shows their average family income is tens of thousands below what is necessary for a typical American household to just get by.
Tens of thousands, wow.
Yeah.
That quickly translates into instability, right?
Right.
What did the SIPP data reveal about their basic security?
Well, when you look at the raw poverty rates, this group sits at a definite 9.63%.
Almost 1 in 10.
And housing instability, so we're talking difficulty paying rent or mortgages or fearing eviction, that's a severe problem impacting 13.64% of this workforce.
And these numbers they're way higher than for clinical staff.
Oh, orders of magnitude higher. It's not even comparable.
Those numbers paint a very clear picture of just constant financial stress. But there's one statistic in the source material that, for me, really pulls the curtain back on the systemic failure of the employment model itself. It focuses on the most basic necessity.
You're talking about food insecurity.
I am.
This truly is the aha moment of the research. The finding is, it's just shocking. Nearly 1 in 4, 24.50% of this essential workforce is struggling to put food on their table consistently.
24.5%. Just think about that for a moment.
It's staggering.
We are talking about individuals who provide intimate, life-sustaining services to vulnerable seniors, to disabled adults, and to children.
Yeah.
And a quarter of them are worried about feeding their own families.
It's an undeniable sign that the wages for this workforce aren't just low. They are systematically insufficient to cover basic living needs in modern America.
So the current arrangement isn't simply low wage.
No, it's dependent on poverty and desperation to function.
So moving from the what to the why? That kind of structural failure doesn't happen by accident?
Not at all.
Why is this essential service relying so heavily on a workforce that is perpetually, it seemed, economically vulnerable? This brings us to the structural roots of this massive inequity.
And the why is deeply, deeply intertwined with racial and ethnic inequity in the occupational structure of healthcare. The financial strain is not distributed randomly.
Okay, so let's look at the specific demographic breakdown. What did the study highlight about the direct care and support workforce?
Absolutely. If you analyze the composition of that workforce, it contains a significant, disproportionate concentration of minority groups.
How disproportionate?
The data shows the highest proportions of Hispanic individuals at 22.41% and non-Hispanic Black individuals at 23.54%.
So nearly half of this foundational workforce comes from those two groups alone.
Right, and yet their representation drops off a cliff in the higher-paying clinical roles like doctors and specialized
So
nurses.
this isn't just about diversity.
Mm,
It's
yeah.
it's an overconcentration.
Exactly. It strongly suggests that racial and ethnic minority groups are disproportionately funneled into and concentrated in these low-wage healthcare jobs.
It sounds like the system implicitly relies on the economic necessity and, the broader socioeconomic disparities facing these communities.
That's the mechanism. It uses those disparities to fill critical but underpaid positions.
So the low wages persist not because the work is intrinsically low value,
No, not at all.
but because there's this large, steady pool of workers, often minority workers, who, due to systemic disadvantages, just have fewer high-wage options available to them.
Precisely. And the structural reliance on economically vulnerable populations to subsidize the cost of care, that's the key to understanding the system's failure. It creates a model built on exploitation, which, aside from the obvious ethical problems, has massive operational consequences.
Which naturally leads to the crucial question. How does forcing nearly 1 in 4 of your frontline caregivers into food insecurity impact the quality and, frankly, the sheer stability and sustainability of the U.S. healthcare system?
I mean, a hungry, stressed worker is not a high-performing worker.
Right.
The operational consequences are dramatic. They hit the system on two major fronts: capacity and quality.
Let's start with capacity. We hear about workforce shortages all the time.
Well, financial hardship is the absolute core driver of the chronic workforce shortage and poor retention.
People are just leaving.
Staff are leaving these positions not because they hate the work, but because they simply cannot afford to stay. If they can make 10 or 15 cents more per hour at a fast food chain or a warehouse, they will leave.
And that leads to, what, high turnover.
Catastrophic turnover rates,
Yeah.
sometimes exceeding 50% annually in some facilities.
50%. And when turnover is that high, you are constantly recruiting, onboarding, training new staff. That has to be expensive.
It is astronomically expensive. The cost of recruiting, background checks, training, and supervision for a single direct care worker can cost several $1,000s.
So if half your workforce cycles out every year,
You are just bleeding money to maintain a fragile, constantly undertrained, and fluctuating staff level. The system is paying a massive inefficiency tax because of low wages.
okay, that covers capacity. Now let's talk about quality of care, which is arguably the most sensitive area. If workers are perpetually stressed, working multiple jobs, what happens to the patient experience?
The quality of care is severely compromised. Think about what compassionate caregiving requires.
Focus, patience.
Attention to detail, emotional availability. Workers who are grappling with food insecurity or housing instability, or who are rushing between 2 or 3 jobs, they arrive exhausted. They simply can't provide that level of sustained, sensitive care.
Did the source material point to specific examples of this quality compromise?
It did. High staff-to-patient ratios, which are necessary because of the shortage, mean rust care. This leads directly to increased medication errors, missed details in patient monitoring, a higher rate of patient falls.
Basic things.
Even lower adherence to basic infection control protocols because staff just don't have the time or the focus to perform every step correctly. Patient outcomes suffer directly because the worker's own survival has to be prioritized over adherence to best practices.
So the system is structurally exploiting economic necessity, and the patients, the most vulnerable in our society, are ultimately paying the price.
They are, through reduced quality, medical errors, and instability in their care environment. It's a heavy burden, and it raises critical questions about the ethics and sustainability of the current arrangements.
So we've established the system is broken at the root level.
Right. It systematically undervalues its most essential service providers. If we want a stable, high-quality healthcare system, we have to address the financial hardship driving this instability.
Which moves us squarely into the conversation about solutions. What specific systemic interventions do the sources propose to address this core driver of the workforce shortage?
The recommended solutions fall into 2 essential baskets: income regulation and job stability. First is a clear policy solution: government regulation to ensure a legally enforceable living minimum wage specifically for health caregivers.
So tackle the income deficit directly.
Exactly. Ensure that workers can meet their basic needs.
And the second bucket, you said job stability.
Right. That's the organizational and policy solution, focused on improving the work environment and making it sustainable. This means mandated, comprehensive benefits.
Things like,
Things like actual paid sick leave, robust work insurance that provides real job security during sickness or a family crisis, and enforced proper day off policies to actively combat that exhaustion and burnout.
yeah, okay. Now, we absolutely have to deal with the inevitable and, the loudest counter argument, which is always the specter of cost.
Always.
If we mandate a living wage and these benefits, opponents will argue it'll lead to prohibitively high costs for patients, potentially collapsing the system. How do we evaluate that?
We have to challenge the premise that raising essential worker wages is a cost we can't afford. The source material argues that this needs to be reframed entirely.
Reframed how?
We aren't talking about shifting the cost onto individual patients. We are talking about a societal investment in critical infrastructure.
So the cost should be borne collectively rather than by individuals.
Precisely. If the stability of the entire health system, which benefits everyone, is dependent on paying fair wages, then the cost should be funded by broader collective financing mechanisms.
Such as?
That can mean increased general taxation dedicated to health system funding or mandatory national health insurance pools. If everyone contributes a small amount, society ensures the stability of the infrastructure without bankrupting the individual patient with unexpected fees.
But doesn't that just sound like wishful thinking to a hospital operator worried about their bottom line right now? They just see the immediate rise in payroll.
And this is where the second counterpoint becomes the most powerful argument. We have to expose the hidden, unaccounted for costs of the current low-wage model.
We are already paying for low wages.
We are, just inefficiently and painfully.
Detail that inefficiency for us. What are those hidden costs?
First, the business costs are massive. As we mentioned, that high staff turnover creates chronic, expensive recruitment and training cycles. Facilities lose money refilling positions that should have been retained in the first place.
And second,
The public subsidy is undeniable. Workers who earn so little that they qualify for means-tested programs like SNP or housing assistance are essentially receiving their living wage subsidized by the taxpayer.
so the taxpayer is already picking up the tab for these large healthcare employers, allowing them to externalize the cost of their labor onto public welfare programs.
Exactly. The low-wage system lets large health systems pay below market wages, while the public treasury makes up the deficit so their employees can eat. A regulated living wage, in this context, isn't an added cost. It's an internalizing of an existing public subsidy, turning it into an investment in stability and quality.
And we shouldn't forget the costs of poor health outcomes. If low wages lead to rushed care, which leads to increased infection rates or patient readmissions,
That costs the health system exponentially more than a decent wage ever would. The long-term costs of instability and compromised quality far, far outweigh the cost of appropriate compensation.
this entire analysis really culminates in one crucial question about long-term stability. If we look 20 years down the road, what is the single most critical change needed to ensure we stop this cycle of shortage, exploitation, and compromised care?
The change has to start with a fundamental governmental shift in professional recognition and valuation of these direct care and healthcare support roles.
What does that kind of governmental shift mean in, legislative or policy terms?
It means officially classifying these essential roles, the caregivers, the support staff, as a critical infrastructure or essential service profession.
That sounds like a foundational classification shift.
It is. It's more than semantics. It's a legislative lever. Once these jobs are officially recognized as critical to national societal health and stability, the same way we view utility workers or first responders, it provides the necessary ethical and legislative foundation to justify and mandate comprehensive public investment.
And that allows governments to enforce those living wages we talked about.
And to fund significant investment in training, robust benefits, and clear, respectable career paths.
So that shift transforms the job from a temporary stopgap position into a respected, high-retention career.
That's the essence of the structural change. It moves beyond short-term fixes and establishes a system built on appreciation rather than exploitation.
This deep dive has been remarkably clarifying. To quickly synthesize the main takeaways for you, the listener, we've established the shocking statistical reality that nearly 1 in 4 direct care workers faces food insecurity, directly linking that financial hardship to the chronic labor shortage.
We've shown that this instability is rooted in structural, racial, and ethnic inequities in occupational distribution.
And critically, we now know that solving this crisis requires systemic solutions. regulating wages and benefits, and correctly framing the compensation cost as a necessary societal investment rather than an individual patient burden.
What's fascinating here is how the source material reveals the government's current implicit reliance on financially vulnerable groups to maintain a core societal function. And the question we should end on for you to explore is this.
Go on.
If the stability of the healthcare sector hinges on recognizing the caregiver as critical infrastructure, what essential low-wage jobs in other industries, in early childhood education, sanitation, transportation logistics, are similarly undervalued due to economic and racial disparities? And how soon before the financial hardship in those sectors threatens the stability of the entire national economy? The healthcare crisis might just be the clearest template for a much wider systemic failure.
Something to think about. Thanks for diving deep with us today.